Tokyo Live
Endoscopy
Endoscopy 1.
Welcome to the session of colorectal cancer screening. I am Dr. Noriko Suzuki from Boston Unit Endoscopy St. Mark's Hospital, UK. I am co-chairing with Professor Yasushi Sano, Director of Gastrointestinal Center, Sano Hospital, Kobe, Japan. Colorectal cancer screening has been proven to be an effective modality to reduce mortality from colon cancer, but still some issues. So two eminent experts are discussing about issues in this session. Now, it is great honor to have a special commentator, Professor Shinji Tanaka. As everyone knows, Professor and Director of Endoscopy Department and Medicine at Hiroshima University, and he takes various important roles, including a Vice President of JGES. I'm handing over to Professor Sano.
Thank you very much, Professor Suzuki. So that I'm Dr. Sano. And let me introduce Professor Matsuda. And Dr. Matsuda is a director of the Cancer Screening Center and a staff doctor in the Endoscopy Division at the National Cancer Center Hospital, Tokyo. And he is licensed as a professor status of the JGES, JSGE, JGA, and lots of GI societies. And he is a chief conductor of the Japan Polyp study, and which is an ongoing multi-center randomized controlled trial in Japan. And his research interest lie in colorectal cancer screening, post-polypectomy surveillance, and endoscopic diagnosis and treatment of early colorectal cancer and imaging endoscopy. So today he gives a lecture entitled Current Status and the Future Perspective of Colorectal Cancer Screening and Surveillance in Japan. So Professor Matsuda, would you start your presentation?
Thank you very much, Professor Sano, for your kind introduction. It's a great honor for me to join this session. There are no COI with regard to today's presentation. This is agenda of my talk today. First, let me talk about the current status of colorectal cancer in Japan. As you can see here, colorectal cancer is ranked as one of serious cancer mortality in both male and female in Japan. Especially in females, colorectal cancer is ranked as first cancer cause of death. In recent years, more than 50,000 people die from colorectal cancer annually in Japan, and this number is higher than US, which is about 2.5 times rather than Japanese population. Furthermore, in the UK, which is about half of Japanese population, the number of colorectal cancer deaths is about 1/3 that of Japan due to the enhancement of organized screening program. I will explain about current issues and the future perspective of colorectal cancer screening in Japan. In Japan, we have two types of colorectal cancer screening. The first one is population-based screening program. The other one is opportunistic screening. We started population-based colorectal cancer screening using 2-day immunochemical FOBT FIT annually for all people over 40 years since 1992. In contrast, in the opportunistic screening program, several modalities, including total colonoscopy, are used as a primary screening tool. This slide shows the results of population-based colorectal cancer screening conducted in 1,800 local governments in 2016. Over 8.5 million people have undergone FIT as a population-based screening. As you can see that the participation rate was only about 15 to 20%. of which 7.6% were FIT positive and recommended colonoscopy as a diagnostic examination. Unfortunately, only 8.5% of them have undergone diagnostic colonoscopy. In 2016, colorectal cancer detection rate was 0.23% of all participants. In Japan, population-based cancer screening program is conducted in each local government. In addition to population-based cancer screening, there are occupational medical examination and opportunistic screening. Therefore, unfortunately, accurate data collection is impossible. In order to realize an organized cancer screening like UK, it's necessary to build a national screening database. In Japan, nationwide cancer registries started in 2016. Moreover, Japan Gastroenterological Endoscopy Society, JGES, has planned and started the Japan Endoscopy Database, JED project. If all these data can be successfully linked, it will be an ideal database. As I already mentioned, colorectal cancer screening in Japan has various problems. Then, should we shift to endoscopy-based screening? We conducted an interventional study to assess safety and accuracy evaluation of screening colonoscopy targeted on an isolated island. We extracted 40 to 79 years old, 4,645 people living in Izuoshima, Tokyo, from the basic resident registration system and sent an invitation letter to provide free colonoscopy screening combined with FIT to all the subjects. Screening colonoscopy was carried out in Izuoshima by skillful endoscopists. Cumulative participation rate for the 3 years study period was 28.5%, and 1,325 people underwent both colonoscopy and FIT. Colonoscopy completion rate was 99.5%, and complication rate was 0%. This slide shows the result of colonoscopy screening in asymptomatic population. As you can see here, adenoma detection rate and advanced neoplasia detection rate was 51.8% and 9.5% respectively. Among 1,325 participants, we found a total of 33 colorectal cancers, including 11 invasive cancers. The screen sensitivities of FIT for invasive cancer and advanced neoplasia were 100% and 31.7% respectively. According to the result of Oshima study, the following points became clear. The advanced neoplasia detection rate by colonoscopy screening was extremely high. Therefore, it should be taken into consideration for use in population-based colorectal cancer screening. On the other hand, FIT revealed good sensitivity specificity balance. Therefore, we should discuss how to incorporate colonoscopy into FIT-based screening. Akita popcorn trial. This is randomized control trial to evaluate the effectiveness of total colonoscopy in colorectal cancer screening is now ongoing in Japan. The final result of Akita popcorn trial will be reported in 2025. From now on, we need to discuss and prepare for the start of colonoscopy screening in Japan. When considering colonoscopy screening, it's necessary to consider the capacity of colonoscopy in Japan. Currently, nearly 3 million total colonoscopies are carried out annually in Japan by national insurance. Risk stratification is required for efficient use of colonoscopy. We conducted a retrospective study targeted on a screened population of asymptomatic individuals. We aim to examine the prevalence and risk factors of advanced neoplasia and clarify high-risk individuals requiring intensive screening. This is a proportion of individuals with advanced neoplasia and 4 adenomatous regions. Among the all individuals, 225, 4.3% had advanced neoplasia. We assessed the multivariate analysis, male gender, elder age, colorectal cancer family history, higher BMI, and smoking index. Such factors are considered as an independent risk factor for advanced neoplasia. Based on the beta coefficient, we calculated the risk score for all factors. We divided into 3 subgroups based on the risk score. The prevalence of advanced neoplasia was 1.6% in the low risk group, 5.3% in the moderate risk group, and 10.2% in high risk group. Based on the result, I would like to propose modified colorectal cancer screening program using risk score. According to the risk score model, we classify into 3 groups. For the people classified into low and moderate risk, we should recommend FIT test first. Of course, the people who judged as FIT positive recommended FIT. We strongly recommend to receive diagnostic workup colonoscopy. On the other hand, the people who classified into high risk should be recommended colonoscopy first. Japanese colorectal cancer screening program have not yet been effective enough in terms of mortality reduction due to the low participation rate for screening, low rate of referral for diagnostic examination after positive FIT, and lack of nationwide screening database to establish an organized screening system. We should discuss how to incorporate colonoscopy into FIT-based screening in Japan. Risk stratification using risk scoring model might be one promising solution. Next, I will explain about current status and future perspective of post-polypectomy surveillance in Japan. Last year, US and EU issued revised post-polypectomy surveillance guidelines. As you can see, the US guidelines provide detailed surveillance intervals for each baseline colonoscopy finding. In contrast, EU guidelines specify 2 subsequent recommended surveillance intervals based on the baseline colonoscopy findings. It seems that they want to secure colonoscopy capacity by not conducting intensive surveillance for low-risk groups. A new post-polypectomy surveillance guideline has been issued in Japan as well. Since this guideline aims to prevent not only the colorectal cancer deaths, but also the occurrence of invasive cancer, a slightly shorter interval is set compared to the Western guidelines. In the recent years, PCCRC post-colonoscopy colorectal cancer has attracted attention, and its risk factors are also being investigated. Finally, I would like to introduce our Japan polyp study and think about the cause of PCCRC. The Japan polyp study, JPS, is a multi-center randomized control trial conducted at 11 participating centers. In this study, we performed 2 times complete colonoscopy before randomization. A total of 3,926 patients were enrolled in this study. Finally, a total of 1,464 patients was selected in per protocol analysis. During 3 years follow-up period after 2 times complete colonoscopies, we found a total of 29 advanced neoplasia in 28 patients. Among all 29 advanced neoplasia, there were 1 invasive cancer, 13 high-grade dysplasia, and 15 low-grade dysplasia over 1 centimeter in size. Regarding the location, 45% of advanced neoplasia were located in the right-sided, 38% were in the left-sided, and 70% were located in the rectum. Morphologically, 62% of advanced neoplasia were classified into non-polypoid colorectal neoplasms, and most of them were laterally spreading tumor non-granular type. These are representative examples of metachronous LSD energy lesions. Among all advanced neoplasia, 15 of 29 lesions were LSD non-granular region. As a risk of metachronous advanced neoplasia, those with LSD energy in the baseline colonoscopy were identified as the strongest factor. This is a final slide. Recently, the JGS post-prolepectomy surveillance guideline has been published and is expected to be widely used in Japan. According to the results of our Japan polyp study, LSD non-granular type was considered as one of the main causative region of PCCRC. From the long-term follow-up data of the Japan polyp study, it's necessary to extend the surveillance interval for low-risk group and increase the capacity for screening colonoscopy. Thank you very much for your kind attention.
Yes, thank you very much for your wonderful presentation regarding the colorectal cancer screening and the surveillance and Japan polyp study. So now we open the question. So Professor Tanaka, do you have any question?
Professor Matsuda, thank you very much for your excellent talk. I'm very impressed your combination strategy of FIT and CS are based on risk of each patient. On the other hand, in the future, I think that the introduction of colonoscopy for population-based colorectal cancer screening will be also important and positively considered in Japan. In such a situation, how should total colonoscopy be applied concretely? Do you have any idea?
Thank you very much, Professor Tanaka, for your insightful question. As I mentioned in my presentation, since the capacity of colonoscopy is limited in Japan, therefore it's maybe necessary to consider or discuss about the use of risk stratification into colorectal cancer screening. Another solution is colonoscopy screening at a certain age, for example, 50 years or 60 years. But it's necessary to discuss about the appropriate age and the number of times is very important.
One more, okay. As in London, how about nurse colonoscopists or use of capsule endoscopy? What do you think?
Thank you very much. It's a very difficult question, but at the moment, maybe it's a little bit difficult to ask the nurse to perform endoscopy. Different situation in Japan now. I know in UK it's available to use such manpower, but at the moment difficult situation. And regarding the capsule endoscopy is promising modality, but the preparation dose of PEG is very big problem now. Therefore, in the future, if we can decrease the dose of preparation, it's promising modality in the screening, colorectal cancer screening.
Thank you so much.
Thank you very much, Professor Tanaka. So I'd like to ask you one question, Professor Matsuda. So from the result of Japan polyp study, you mentioned LSD-NG is a candidate region as a post-colonoscopy CRC. So I want to ask you, so how to reduce the overlooking of the non-polypoid or flat region or LSD non-granular type in screening or surveillance colonoscopy? Do you have any idea?
Thank you very much, Professor Sano. It's a very important question. NBI observation with good boil preparation has been reported to contribute to improve adenoma detection rate. In addition to utilizing image-enhanced endoscopy, I'd like to expect AI as well. Moreover, I believe that it's very important to always pay attention to non-polypoid colorectal neoplasm during screening and surveillance colonoscopy?
Yes, I totally agree. So once we see the flat region or deposited region, we can identify the such regions. And so that one more question. So regarding sessile-related lesion, in the Japan polyp study, post colonoscopy, advanced neoplasia or invasive cancer, so sessile-related lesion derived, cancer derived from sessile-related lesion, I think it's very few in the Japan polyp study. So how do you think about the clinical significance of sessile-related lesion on PCCRC?
Thank you very much. According to our data, Japan polyp study, among the all metachronous advanced neoplasia, serrated lesions is just one lesion among a total of 29 lesions. Therefore, very low incidence. However, as you know, the Japan polyp studies follow-up period is just 3 years. So if we follow up more longer, I don't know the percentage of serrated lesions among the all advanced neoplasia. And moreover, prevalence of Japanese population, Asian populations, SSL may be lower than the West. So we need to assess in this issue more in the future.
Okay, thank you very much. So do you have any question? Okay, so I am sorry. Finally, so I forgot a very important introduction about you because so Dr. Matsuda becomes professor of Toho University in this month. So congratulations, Professor Matsuda.
Thank you very much.
So yes. So move on. Next speaker. Would you introduce Professor Shu Suzuki-sensei?
Thank you. So it is my great pleasure to introduce Professor Hammo Chu from National Taiwan University. Professor Chu takes many important international roles, including the Secretary General of the Gastroenterology Society of Taiwan. And he has been devoted to the research of colorectal cancer screening and colonoscopy for 2 decades. And he has various publications in this field. I'm really looking forward to his lecture as one of the screening colonoscopists. Thank you very much, Professor Chu.
Okay, thank you, Professor Suzuki, for your kind introduction. So it is my great pleasure to be invited to Tokyo Live 2021. I'm Dr. Hammo Chu from National Taiwan University Hospital. Today, I would like to talk about whether we should use FIT or colonoscopy as the primary screening modality in population colorectal cancer screening. So there are currently 2 mainstream of colorectal cancer screening. The first one is the colonoscopy screening approach, which enables detection of both cancer and the precancer lesion. It can also concurrently resect adenoma during screening procedure, thereby reducing the colorectal cancer incidence. And its main constraint in implementation in large-scale population screening is its high invasiveness and the labor-intensive characters. And its high cost also cause the financial burden to the screening organizer. The second is the high-risk approach using FIT screening, and only those with positive FIT require colonoscopy, thereby confining the colonoscopy workload. And its single test sensitivity for early-stage cancer and adenoma is insufficient. Therefore, repeat screening in 1 or 2 year interval is necessary to detect important lesions that were missed at the previous run. So this slide shows the screening modality that used in the population screening program globally. FIT screening is currently the most popular test in most of the EU and the Asian countries, and the colonoscopy is more commonly used in the US and some EU countries such as Poland and Germany. There are several challenges in implementing colonoscopy as the primary screening modality in a large-scale population screening program. And these include clinical workload, manpower and capacity issue, public preference issue, healthcare financial issue, the effectiveness and the cost-effectiveness issue, and the overdiagnosis issues. So my today's talk will be focusing on the aforementioned important issues that need to be considered in choosing the primary screening modality. Whether colonoscopy could be a viable option as the primary screening exam is largely affected by the size of the target screening population and the capacity and the manpower of colonoscopy. In most of the Asian countries, healthcare services are provided by the government with the so-called single-payer system. Even considering the relatively low cost of colonoscopy in many Asian countries, offering colonoscopy screening is still too costly and labor-intensive. Moreover, the expanding aging population is another hurdle of using colonoscopy as the primary screening modality. We can see the population age 54 to 72 years has expanded twofold in the past 20 years in Taiwan, and such an expansion in the size of aging population has also been observed in many other developed countries in Asia and other in Western countries. So colonoscopy-related complication is one of the major concerns of using it as the primary screening modality. The likelihood of complication was associated with increasing age, existence of comorbidities, and which is also associated with increased age and whether polypectomy was performed during colonoscopy. Moreover, in many Asian programs, there is no upper age limit for colorectal cancer screening, and this increased the concern about screening-related complications in the older age group. As mentioned previously, the likelihood of having comorbidity increased with age, and this may concurrently increase the likelihood of colonoscopy-related complications. Adding the fact that expected life year decreased with increasing age, the cost effectiveness also decreased with age, especially using such an invasive and expensive exam as the primary screening modality. Next, overdiagnosis is another important concern. When there is overdiagnosis, then it may cause unnecessary costs and unnecessary complications. Those subjects would be labeled as disease, which may also cause psychological stress, anxiety, and result in economical burden issued by workup and treatment and the subsequent regular surveillance exam. This slide shows how overdiagnosis happens. In short, when there is only increase in the number of newly diagnosed cancer, but no change in cancer-related deaths, we can reasonably suspect that cancer detected by screening are non-fatal and overdiagnosed. Some colorectal cancer may not cause death before the end of life in the elderly, especially those with comorbidity, and detected as many as possible of cancer in such population may not necessarily lead to decreased colorectal cancer deaths. Prostate cancer screening with PSA or thyroid cancer screening with ultrasound are some of the famous examples of cancer screening with significant overdiagnosis. It was also reported that nearly 30% of breast cancer by mammography are overdiagnosed, and also lung cancer screening with low-dose CT scan. So there is only a few studies on the issue of overdiagnosis colorectal cancer screening. It is inevitable, especially in the elderly population with limited life expectancy and for adenoma, which take a very long time to transform into invasive cancers. According to the result of several simulation models of the natural cause of colorectal neoplasm, the estimated dwelling time from occurrence of adenoma to invasive cancer was 7.6 years by the Misken model and longer than 20 years by other models. The dwelling time from the occurrence of adenoma to the diagnosis of colorectal cancer was even longer, with 10.6 years by Misken model and longer than 20 years by other models. That means overdiagnosis of adenoma or even early stage cancer is very possible to happen in colonoscopy-based screening, especially in the old age group. According to a recent study from Japan, it was demonstrated that the risk of instant advanced neoplasm was not different from those who did not undergo polypectomy for their non-advanced adenoma less than 5 millimeters at screening colonoscopy. Such a finding implies that diagnose and do not resect strategy may be an alternative option for diminutive adenoma, and many of the current surveillance practice for such a low-risk population may be unnecessary and do not contribute to the prevention of colorectal cancer and colorectal cancer deaths. Using colonoscopy-based screening, the likelihood of such an over-surveillance practice may be much higher than that by FIT screening. If colonoscopy manpower and the capacity is taken into consideration, the long queue for colonoscopy will be a great concern if the manpower or capacity is rather constrained. For that matter, FIT-based screening is more efficient, and only selected high-risk population are referred for colonoscopy if we consider the prevalence of colorectal cancer and adenoma in the general population. This slide shows the single test performance of colonoscopy and the FIT. It is evident that the sensitivity of colonoscopy is superior to FIT, but its price is much higher. Please remember that FIT is not a one-off screening test, but should be repeated in 1 or 2 year intervals. Therefore, if we consider the so-called program sensitivity, we take into account the cumulative number of colorectal cancer that detected at different screening rounds. FIT may not be inferior to colonoscopy if we consider the compliance to screening or adherence to repeat screening by the public. In this Spanish trial comparing FIT with colonoscopy, FIT screening had a 10% higher participation rate than direct colonoscopy screening, which resulted in similar detection of invasive cancer by intention to treat analysis, though the detection for adenoma was higher in the colonoscopy arm, which highlighted the crucial role of public participation. If the compliance of the public to screening remain consistently lower by the colonoscopy screening may not necessarily be superior to FIT screening after a long time span. The efficacy of reducing colorectal cancer or colorectal cancer death by direct comparison of colonoscopy and the FIT screening remain unclear, and there is so far no direct evidence from randomized controlled trial. There are 3 large-scale ongoing randomized controlled trials comparing the efficacy of preventing colorectal cancer by annual or 2-yearly FIT screening with 10-yearly colonoscopy in the US and the EU countries. The demand for colonoscopy is rather steady if only screening colonoscopy or diagnostic colonoscopy after positive stool test is taken into account, given stable population size, screening uptake, and the positivity rate of stool tests. However, if surveillance colonoscopy is further taken into consideration, the demand would be much higher and increase along with the expanding aging population. If we use colonoscopy screening, such demand for surveillance exam would be much larger than by FIT screening, and the impact largely on the already overstretched colonoscopy capacity. The purpose of using colonoscopy as the primary screening modality is that it has superior sensitivity to detect adenoma. But is it really worthwhile to do this when considering the trade-off between additionally detecting neoplasm and the cost? Is there a so-called sweet spot or marginal effect of increasing ADR by colonoscopy? Maybe. So it is likely that endless pursuit for extremely high level of ADR by investing huge amount of money may compromise cost effectiveness of screening, because more people may require surveillance colonoscopy, and the surveillance colonoscopy will detect more small lesion, and again issue more and more future colonoscopy. This simulation study by USPSTF has demonstrated that if we compare 10-yearly colonoscopy with biennial FIT screening, the number of colorectal cancer that prevented is 30% higher by colonoscopy, but at the cost of 3.3 times the total number of colonoscopy to be performed. If it is compared with annual FIT screening, then the number of averted colorectal cancer is similar, but only require 2/5 of colonoscopy by FIT screening. The colorectal cancer screening how to reach our underserved population may not be compliant to the colonoscopy-based screening, which is deemed as a more costly way of screening. For example, in Taiwan and some other Asian countries, the national insurance does not subsidize the fee for conscious sedation, and out-of-pocket expense become the obstacle for screening participation. In this US study, more underserved population participated in FIT screening, and as a consequence, the number of detected advanced neoplasm was not different from colonoscopy-based screening. Over-surveillance is another important concern. Though it may happen in both colonoscopy or FIT-based screening, the number of unnecessary surveillance procedure would be larger in the former group. In this US study, nearly 1/3 of the people who were suggested 5-year surveillance and 40% of those who had no neoplastic lesion and assumed to come for surveillance 10 years after colonoscopy actually came much earlier than suggested. This slide shows the current existing surveillance guideline in the Asia-Pacific region. Most of the countries set shorter surveillance interval, which may increase the demand of surveillance procedure, except for the Australian program, which followed the US guideline. Moreover, according to a recent Korean study, given already a shorter surveillance interval compared with the US guideline, most of the survey respondents favor an even shorter surveillance interval than recommended by the current Korean guideline. So please rethink some important points before making a rash decision on implementing colonoscopy screening. Firstly, have you ever evaluated the effectiveness of the current FIT screening program in your country? It may be better than you expected. Secondly, the public preference in your population should be assessed in a very objective way. And thirdly, evaluation of the current endoscopy capacity and the manpower taking into account the demand for surveillance procedure and also the demand for nursing staff and the non-GI doctors such as anesthesiologists is an indispensable step. Finally, securing sufficient and sustainable funding support is mandatory, and we should also revisit the current recommendation on the surveillance interval. This slide shows the 10-year result of the Taiwan colorectal cancer screening program. The overall effectiveness in reducing colorectal cancer mortality was 35%, and the advanced stage colorectal cancer was 29% after adjusting for possible selection bias and the changing epidemiology of colorectal cancer in Taiwan. If compared with the effectiveness of colonoscopy-based screening in US, which reduced colorectal cancer deaths by 53% and 56%, the currently observed effectiveness in FIT program is acceptable if the number of colonoscopy that performed is taken into account. In the sensitivity analysis of our study, it was also revealed that if colonoscopy quality could be further improved in terms of high sickle intubation rate, then we can expect an additional 5% gain in effectiveness in reducing colorectal cancer mortality and the incidence of advanced stage cancer, approaching the effectiveness by colonoscopy-based screening. And finally, we should not forget that in the Asia-Pacific region, colorectal cancer is not the only important GI disease to combat with. Compared with Western countries, we have a higher burden of HBV, HCV-related liver disease, such as liver cirrhosis, liver cancer, and H. pylori-related disease, such as peptic ulcer disease and gastric cancer in this area. We should make the most efficient use of constrained healthcare resources. Ladies and gentlemen, this is the take-home message of my today's presentation on this topic. Currently, there remain lacking direct evidence from randomized controlled trial demonstrating the superiority of colonoscopy over FIT screening. And while considering which screening modality should be used in large-scale population screening, we should not only consider the efficacy or effectiveness of certain screening modality, but also cost effectiveness, the available healthcare resources, including funding support, clinical capacity or manpower, and the public acceptance of such a screening test. Thank you very much for your very kind attention.
Thank you very much, Professor Chu. What a fantastic, very balanced lecture. If I may, I want to start asking questions. You mentioned the quality of colonoscopy gain some 5% of reducing mortality rate. So fundamentally, screening colonoscopy has to be in a high quality. Would you like to comment on quality control issues? And also, who should be a provider? Who should do colon cancer screener? I want to ask same question to Professor Tanaka after your answer.
Okay, thank you very much for asking this very important question. So quality assurance is actually one of the most important aspects of colorectal cancer screening. So in our screening program, we use FIT as the primary screening test. So the prevalence of neoplasm in FIT positive population is much higher than that in the setting using primary screening colonoscopy. So recently in our program, we set a benchmark quality threshold for colonoscopy of fecal intubation rate of 95% and adenoma detection rate of 40%. I think the adenoma detection rate is the threshold is much higher than that in the primary screening colonoscopy setting. But according to our previous Asia Pacific multinational study, it showed that FIT can increase the likelihood of having advanced adenoma or cancer. So I think 40% is a minimal requirement in FIT screening program. But however, according to our recent analysis, both fecal intubation rate and adenoma detection rate, or both combined, could only explain about 70-something% of the PCCRC improvement. So as mentioned by Professor Matsuda, the ability to detect LST-NG by an endoscopy is a very important performance indicator, but however, it cannot be reflected by currently used quality indicators such as fecal intubation rate or adenoma detection rate. So maybe in the future, we should further consider what is the necessary capability of an endoscopy to perform screening colonoscopy.
Thank you so much, Professor Chu, for your wonderful presentation. Professor Suzuki's question. I have no concrete criteria regarding colonoscopy provider. However, there is skill of total colonoscopy insertion and certain ADR are essential. So I have one question to Professor Chu. In colorectal cancer colonoscopy screening, since a certain level of colonoscopy skill is required, it is necessary to establish a training system and qualification system. Do you have any countermeasure or system in Taiwan?
I'm sorry, currently we still don't have a very formal accreditation system in our screening program. Maybe in the future, we should construct this kind of accreditation or training system, formal training system. Maybe by a joint program of our endoscopy society and the national screening program. But I know that the UK is probably one of the countries that has the most strict requirement and the accreditation system in the world. So maybe Professor Suzuki can answer this question on my behalf.
Yes, to be a screener, I already had the paper test and also practical test that we have to pass. And my key performance index has been monitored since becoming screening consultants. So every 3 months, there's a feedback in relation to key performance index. So we are monitored strictly. Professor Tanaka, any additional comment?
I have one more question. Professor Chu, do you have any idea about colon capsule endoscopy for CRC screening in Taiwan?
Yeah, considering the reimbursement by the health insurance, I think currently no way to implement colon capsule in mass screening setting, I think, because colonoscopy itself is only $70 in Taiwan. But I think colon capsule maybe 10 times of the price of colonoscopy. I think it is a big hurdle for screening uptake. So I think it's quite difficult to use colon capsule in mass screening.
Thank you.
Thank you very much. Any other questions from the other?
Yes, I want to ask the same question. How about clinical significance of sessile salivary lesion on PCCRC in Taiwan?
Yeah, currently I don't have this kind of data, but in the upcoming future, we want to explore the genetic profile of PCCRC, either so in the future, maybe we can see whether the proportion of BRAF mutation cancer in amongst all the PCCRC. Maybe at that timing we can answer this question. But as mentioned by Professor Matsuda, the prevalence of SSL in Asian population seems lower than that in the Western population. And currently, we are also not aware of the real risk factor of SSL. Maybe some dietary or some ethnic factor may affect the risk of SSL. But sorry, I currently don't have answer.
Thank you, but it's a very interesting fact in the Asian countries. Thank you very much.
Thank you.
Thank you. Thank you very much for the fantastic talk. Now, Professor Sano is going to close the session.
So I'd like to close the session. I'm convinced that today's topic regarding colorectal cancer screening was a great learning experience for many listeners. But I guess many challenges remain regarding research on colorectal cancer prevention. I hope that you will continue to play an active role in this field. So thank you, Professor Matsuda and Professor Shu, for your excellent presentation. And thank you for Professor Tanaka and Professor Suzuki for joining this wonderful session today. And finally, I thank you for Professor Inoue for giving us this wonderful opportunity. So hope to see you in Vienna. Thank you all.